Thank you for joining us for today's NILE webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, please locate the chat box in the bottom left-hand corner of your screen. If you have any questions, type them in the chat box and we will address those questions at the end of the presentation. Secondly, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will be sent out by the end of today, and all CEUs will be mailed out within the next week. A little disclaimer, Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. And lastly, if we get disconnected for any reason, please call right back and we will continue the webinar. I'd like to now turn it over to our speaker, Charmian Lyons, a cancer nurse navigator at Renown Health Institute for Cancer. In this role, Ms. Likens provides coordination of care and educational support for breast cancer patients and for cancer survivors. She has also worked as an oncology certified and chemotherapy certified inpatient oncology nurse at Inova Fairfax Hospital in Virginia. Ms. Likens has earned her master's in public health with an emphasis in occupational and environmental health from Johns Hopkins University, as well as a BSN in nursing from George Mason University and a BSB in business finance from the University of Minnesota. Thank you so much for joining us today, Charmian. I'll turn it over to you.
Thanks, Brianne. Hi, can everybody hear me okay? I've had my foot in both the worlds of oncology and primary care for quite some time, and it's been my experience that there's been some confusion on the part of both patients and providers regarding whether or when to immunize as it relates to cancer treatment. And there is no one-size-fits-all answer, but I'm hoping that today I can share some tools you can use to help you decide when and whether immunizations are appropriate after a diagnosis of cancer. But I do have a little poll to start off with, just to kind of see who's here. And that way, if you could just click, I'll try to tailor what I talk about based on who's attending today. Okay. All right.
And we'll give you guys just a couple more seconds to answer that poll, and then we'll go ahead and show those results for you.
Okay. Well, I can't tell if everybody has participated in this. Hopefully you can see the results here. It looks like it's mostly other. We have some oncology nurses, primary care nurses, and physicians. Great. All right, well, let's get started. So we'll talk a little bit about cancer survivorship in general in terms of demographics, late and long-term effects of treatment, and then we'll get into use and timing of immunizations as related to cancer treatment, some contraindications, and so hopefully we'll be able to identify patients with immunization gaps after the cancer treatment is done. And also I'm going to give you some places where you can find more information. So I just want to say, full disclosure, the ongoing health of cancer survivors is an enormous topic, and we're just going to scratch the surface. But again, I hope that it will be useful for you to know where to go next to get more information. So I guess the first thing is to define what a cancer survivor is. And back in 1996, the National Cancer Institute suggested that a cancer survivor is someone from the time they are diagnosed through the balance of their life, and it also included family members, friends, and caregivers in their definition. However, for the purpose of this talk, we're going to focus more on the Memorial Sloan Kettering definition, which is really focusing on a particular period in a cancer patient's life, which would be post-treatment and not including end-of-life care. So this is just a nice infographic of a very generalized cancer treatment trajectory. And depending on the potential treatment options and the patient's goals, the treatment might be intended to be curative or palliative. And then after treatment, the cancer may be cured or it may be managed like a chronic disease. So we're going to be mainly focusing on the patients that would fall into that pink box today. So a little bit of demographics, especially for you in primary care. The American Association for Cancer Research projects that the number of cancer survivors are going to increase by 68% by the year 2040. And the reason for this is there's a lot of different parts to that. First of all, our population is aging. We are doing better at screening and we are catching cancers earlier. We have better curative treatment as well, so we have more success at eliminating disease. And we also have better palliative treatment. So we have more success at managing late-stage disease and treating toxicities. So that would include more people in that group of survivors. And then we have a bullet point at the bottom there, more women survivors. And why do you think that is? Well, it's because of breast cancer mainly, because we'll look at the breakdown in a few minutes, but they're the majority of cancer survivors. So this chart shows the prevalence of cancer survivors in the population by how far out from treatment they are. And you can see that there's not a huge projected change for people in their first year of survivorship. And these people are usually still closely followed by their oncologist. But if you can see the other categories, the patients who are 5 years out or more, they're usually seeking most of their care in the community, just in general. And that's those green, purple, and blue categories. And when you use the word survivor, it can cover any number of variations on disease type or treatment. And you can see that female breast, prostate, colorectal, and melanoma make up almost 2/3 of adult survivors. So the point is, when we're talking about cancer survivors, we're talking about a very diverse group. And even within these categories, treatments and prognoses vary. So one size does not fit all. That's going to be my theme. I do want to touch on another demographic, and that is a unique subset of survivors. And that is those adults who were originally diagnosed with cancer during childhood. Now, these kids have been the canaries in the coal mine that have informed our understanding of the complexities of survivorship for adults. So cure rates are now approaching 80 to 90% for many childhood cancer subtypes. And the data from the earliest cohorts of kids that have completed and had successful treatment is now over 25 years. There's a study going on where health outcomes are compared to siblings, and we've learned a lot from that survivor study. The implication of that is you will be seeing more patients with a remote history of childhood onset cancer. But I do want to point out that survivors of pediatric versus adult onset cancers, they may have similar but not identical risks of late and long-term effects, mainly because childhood cancers and adult onset cancers can often arise from different tissues. They are treated through different protocols. Adults oftentimes come into treatment with more comorbidities, and then pediatric patients have growth and development issues that may not be an issue for adults. And in terms of coordination after care, it is not your imagination. Follow-up recommendations are by no means harmonized. In this 2017 Journal of American Medical Association paper, they looked at 41 guidelines published between 2010 and 2016, and they found that most of the guidelines were ambiguous. Some of them recommended against tests that other ones recommended for. They recommended frequency but not stop time, etc. So, I mean, we need better research on this for sure. So, in 2016, the Institute of Medicine published a landmark report entitled From Cancer Patient to Cancer Survivor, Lost in Transition. One of the recommendations was to put in place a standard communication process between oncology and primary care. And what they came up with was something called a survivorship care plan. And my question for you is, have you ever seen a survivorship care plan in your practice? So here's a little poll. You can check yes or no, and then let's see where we're at. Okay. We'll give you another minute. So I don't know if you guys can see these results. It looks like the majority of people, 2/3, have never seen one, and 1/3 have seen them. So let's take a look at what it looks like. Let's try to take a look. Oh, here we go. Oh, I forgot. I needed to ask you another question. If you did see it, that 1/3 of people who did see a survivorship care plan in their practice, did you feel like it was helpful or not? Okay, 100% yes. Oh, and it depends. Okay. All right. So we have for results about 78% thought it was helpful, 22%, 36% says it really depends. That's changing. Now it's 50 and 50. I would agree with the people who says it depends, mainly because this form is really what's on it. I'm going to show you an example. This is a sample survivorship care plan. This one comes from the American Society of Clinical Oncology, and it's a template that you can find online. Some organizations have adapted it to use for their patients. Renown has adapted it, but there are a lot of other different templates out there. But the idea behind it is that it has information about the treatment team at the top, the diagnosis and treatment as a summary, in a summary format, and then the follow-up care plan. And I think it's been my experience that the follow-up care plan sometimes is where we could use better coordination on these plans. And also, when you get a piece of paper like this, it represents a snapshot in time. It's not really an ongoing living document the way it should be. So it's something that we are trying to make a better process. But one thing I would say to primary care is ask your patients to share this with you. If they were treated for cancer at an accredited center, they should have gotten one. And if they don't have one, you can ask them to request one from their cancer care team. All right, so just briefly, what are late and long-term effects after cancer treatment? So long-term effects are effects that are caused by cancer or its treatment that started during that treatment but continue until after the treatment is done. Late effects are a little bit different in that they show up maybe after the treatment is done, and they can be separated from treatment by many years or decades even. And again, what to expect, it depends on the stage upon diagnosis, what kind of treatment did they get, how long has it been since they were treated, and what other comorbidities do they have. So we'll talk about each of the modalities briefly. For surgery, you're probably all pretty familiar with the late effects of surgery, but for cancer survivors, body image and sexual dysfunction loom large because do you remember which two cancer sites are the most prevalent? Are breast and prostate. But you notice asplenia down at the bottom. That is not for all cancer patients, but for ones who did have their spleen removed. And as most of you are probably aware, that plays a role in immunization needs. So we'll talk more about that in a few minutes. Okay, radiation. Are patients who receive radiation radioactive? Another quiz. Okay. Okay. So let's give that one more minute. People are still thinking. All right. Well, looks like we have 13% say yes they are, 60% say no they are not, 26.7 say they might be. It's a maybe. Okay. Well, we'll get to radiation in a minute. Let's talk quickly about chemotherapy. So this is just a quick biology refresher. Chemotherapy interrupts the process of creating daughter cells, and chemo doesn't discriminate between healthy dividing tissue and cancerous tissue. And different drugs work at different points in the cell cycle. So here is a chart, and I'm not expecting you guys to remember all of them, but it shows some representative examples of late effects of different chemotherapies. So I would like to beseech you to find out what drugs your patients received and look up what potential late effects those drugs might have. For example, a patient who received a lot of bleomycin, which is down under here under alkylating agents, might be at great risk for a respiratory compromise if they go scuba diving, or they might not, but they might have pulmonary fibrosis, so you might want to consider a PFT test. Up to Date has a really good section on bleomycin lung toxicity. Another one would be the heart problems, the cardiomyopathy with the anthracyclines. So just to be aware of what treatments, what drugs your cancer patients have had is going to help you a lot to determine what their needs will be after treatment is done. Okay, here we get to radiation. So radiation kills dividing cells by causing damage to the DNA. And it can be given by external beam, which means that it passes through the tissues, interfering with that DNA of the dividing cells. Or it can also be given internally by beads, like for prostate cancer, and those beads might remain in for a period of time. Or it could be through devices that are inserted temporarily and then taken out. So radiation that's given externally or by those removable devices does not stay with the patient. But the beads that remain in do continue to emit radiation for a while. So the people who answered the maybe on that quiz were correct, because sometimes yes, sometimes no. So in terms of late and long-term effects of radiation, it all has to do with where the radiation was done. And so the field and the total unfractionated dose is really what makes the difference. And this is why having that survivorship care plan or having information about what treatment your cancer patients had is super important. Just think of like a patient who had radiation to the neck. So risk would be to the structures in that area, the thyroid, for example, or swallowing, or weight maintaining. In terms of immune status, you'd want to think of the hematopoiesis centers, such as bone marrow, spleen, for kids, the thymus. And then a good resource it has patient education information as well as for providers, is astro.org, is a great place to find information about radiation late effects. Okay, so immunotherapy, the new kid on the block. Probably you guys know something about it. Researchers have been trying to hack the immune system's power to eliminate cancer cells for over 100 years. Coley's toxins were killed bacteria that were injected into patients, and that was based on observations by this Dr. Coley way back when, that a patient's tumor regressed after a serious skin infection. It was dangerous, and patients died, and it wasn't well controlled, and it stopped being used. Back in 2007, they released a medication called Provenge, and it's a prostate cancer vaccine. They don't use it as much. It really hasn't lived up to its promise. The checkpoint inhibitors are actually being used more and more now, and they're being approved for new indications all the time. And you can see they have a lot of them. They're coming out it seems like every month. Maybe that's too frequent, but they're coming out a lot. Checkpoint inhibitors are basically T cells on patrol that assess proteins on the surfaces of cells. And that's to determine whether they are self cells or enemy cells. And the T cells, if they determine it's a danger, they'll attack. But what cancer cells they commit identity theft, and they wear these proteins that make them look like normal cells to the immune system. And so they inhibit the checkpoint inhibitors block these proteins so that T cells can identify the cancerous cells. So basically, checkpoint inhibitors inhibit the inhibitors. It's a double negative, if you will. And then the CAR T cell therapy is a designer medicine. Very exciting. It's where they take T cells from a patient and genetically engineer them to attack the patient's cancer cells. And it's FDA approved for some advanced leukemias and now lymphomas. So these, just to go over the words cancer vaccines, HPV vaccine is really the only preventative one against a cancer. The other vaccines, what they might call vaccines, are really more to harness the immune system's power to destroy those non-self cells. And they're not, most of them not used in the first-line treatments. And in terms of toxicity, the side effects are related to increased immune response in general for immunotherapy. And they haven't been around in use long enough to have a good handle on the late effects. But as an FYI, if you're caring for a patient who's currently receiving immunotherapy, remember they can ramp up immune response. So while you'd want to rule out infections, you'd also want to consider hyperimmunity. So always communicate with the oncologists about these patients. And then lastly, in terms of late and long-term effects, there are some that are related not to the treatment per se, but for the supportive care that happens during the cancer treatment. And this is most often seen for people with leukemias and lymphomas, but it can be seen in patients who have had multiple treatment regimens or later stage disease treatment. If they have had a lot of treatment that requires red blood cell transfusions, they might have iron overload. And it can be seen as soon as 3 units of packed red blood cell transfusions. So you can look at the serum ferritin. It can cause depositions in tissues, including the spleen, which might affect immunity. Also, these patients might end up having multiple treatments with broad-spectrum antibiotics. And that can change their gut and their dental flora. It can increase their susceptibility to the multi-drug resistant organisms. And all of this has to do with the fact that if you're getting a systemic therapy, it can affect the bone marrow function. And sometimes that bone marrow can be suppressed for an extended period of time, especially for those hematological cancers. All right, so let's get into vaccines a little bit. So cancer and immunity, it's complicated. Inflammation can increase cancer risk. Immunity can be impaired by treatment. Immunity can be harnessed to kill cancer cells. And immunosuppression can increase cancer risk. So what does that mean for vaccines? Well, there are general guidelines. And I'll go over this in just a minute. This is just a quick overview, and we're going to talk about each of these parts a little bit more. But I want to just reiterate that communication with the oncologist is important if the patient, especially if the patient is still in treatment or just recently finished. So you want to think about what's the immune status of the patient, what kind of treatment did they do, where in the treatment regimen is the patient. And remember, if it's ongoing treatment, that immune response is going to decrease the most at the beginning with that heavy-duty induction and consolidation treatment. Immune function may recover within 3 months, but this is variable. Did the patient receive blood products or antivirals? And then for the hematologic malignancies, you may or may not need to re-immunize them. Serum antibody titers are something that you can use as a tool to figure out whether that's necessary, and that primary responses to vaccines are more affected by immune suppression than booster responses. So the NCCN, this is a coalition of 27 major cancer centers in the United States, and they have basically recommendations that change periodically, and this is the most recent one. And there are 2 considerations with vaccines and cancer survivors: safety and efficacy. So for all cancer and transplant survivors, the NCCN recommends inactivated vaccines, vaccines made of purified antigens, vaccines made of bacterial components, and genetically engineered recombinant antigens that are non-live. So their specific recommendation is that in the absence of known harm, administration of inactivated vaccines with the hope of achieving some protection may be worthwhile, and the usual doses and schedules are recommended. But then they go on to say, in terms of when to do it, the ideal time would be for all indicated vaccines to be given 2 or more weeks prior to starting treatment, and then live vaccines 4 or more weeks prior to starting treatment. But is this even possible? A lot of times when people are diagnosed with cancer, the treatment has to start right away. So in the real world, this is not going to happen. Treatment of the cancer will probably happen first, and we will need some recovery after the treatment in order to have a proper response to the immunization. So the neutrophils need to recover, and the lymphocytes need to recover. Baseline white blood cell has to be adequate. There can't be ongoing infection. And specifically, they have to be off of immune suppressants. And the way they define immune suppressants is greater than 5 milligrams per kilogram of prednisone or an equivalent, or a combination of 2 immunosuppressants given at the same time. So for inactivated or recombinant vaccines, they should be given 2 or more weeks before treatment starts, or, since that is unlikely for a lot of our patients, 3 or more months after cancer or chemotherapy ends. Inactivated influenza vaccine can be administered during treatment. And I guess the question is, do they mount a full immune response? Well, they'll probably have some protection. And depending on the patient and how profound of a bone marrow suppression that they're having, they may have a full response. In terms of the live viral vaccines, please consult with the oncologist or infectious disease specialist before giving live viral vaccines. The recommendation is 3 or more months after cancer chemotherapy, but if they have had a stem cell transplant or a bone marrow transplant, hematological cell transplant, it's the same thing, you have to wait a good 24 months, and the patient can't have any graft versus host disease and can't have any immune suppressants. A note for our lymphoma survivors, if they got anti-B cell antibody therapy, which would be Rituxan, you need to wait at least 6 months after the last dose of such therapy before you give any live vaccines. So there's a really great article that recently came out that provided a lovely little chart here, and you can see that according to, this is from Memorial Sloan Kettering, they recommend that even during cancer treatment, these vaccines for adults are considered safe and effective. I do want to note that the live vaccines are contraindicated. And they also talked a little bit in this article about the experience there at Sloan Kettering for patients receiving immunotherapy with the checkpoint inhibitors. And they found that co-administration of the flu vaccine with the checkpoint inhibitors was safe and effective. But I would still consult with the oncologist first before doing that if you're on immunotherapy, because it's a new therapy, and because it would be just best to make sure that that would be the right time to do it. All right, so this list is also from the NCCN, but it's just an example because the transplant patients are more complicated, and the transplant center where they got their transplant may have their own recommendations. And the main thing to remember with the hematopoietic stem cell transplant survivors is that their whole immune system has been replaced. And so they may have entirely lost their previous immunity. And therefore they may need to have revaccinations just as if they are a preschool child getting their vaccinations again. And they have recommendations in the NCCN guidelines, which, if I didn't already mention it, are ones that you can sign up and look at their recommendations, which change periodically. Just be very careful with these stem cell transplant survivors and communicate with the transplant center. So travel vaccines are a little bit more tricky because there's not a lot of published information. So it's best to be cautious and balance risk versus benefit. There was an article that was published in 2009 that was specifically related to vaccination of the stem cell transplant population. And their recommendations were that, for example, if you had a patient who needed to travel to a place with hepatitis A risk, that immunoglobulin should be administered because they may not have the ability to mount a strong response to the hepatitis A vaccine. Many patients have already had that hepatitis A vaccine, so it may not be something that's an issue, but just to know that immunoglobulin would be something you could think about. So varicella, you want to avoid it 24 months post-stem cell transplant, and they don't have a lot of data on the safety or efficacy for this medication in this group. Yellow fever, they did specifically say that it's important to examine the risk-benefit balance. If you have a patient that has to go to a place where there's an ongoing yellow fever outbreak, if they're immune suppressed, the risk-benefit balance might tip more into the maybe you should stay and not go to that place until your immunity improves. But they didn't outright say it shouldn't be done for most cancer survivors. It should be avoided 24 months post-stem cell transplant, active GVHD, or on immunosuppression. For rabies, they consider it appropriate if there's a potential occupational exposure. Pre-exposure should be delayed for stem cell transplant patients, and post-exposure with the human rabies, immunoglobulin can be delivered after stem cell transplant, which is an important point. So if it's safe for the stem cell transplant patient, there's no data on just regular cancer survivors, but it would be reasonable to think that it would be, in terms of risk-benefit balance, it would be something you could do. In terms of the encephalitis vaccines, there's no data. For the typhoid shot, it's recommended if the risk factor is present, if you're going to a place with a risk of typhoid. For the oral polio vaccine, it is not recommended. For the BCG or the live influenza virus, not recommended. And then there's no data for cholera, rotavirus, or for this where it says zoster, I think they mean the older shingles vaccine, the live one. So in terms of testing for immunity after the cancer treatment, there was also an article on this. It's from 2004. It's specific to children and not to adults. It did find that the children that they looked at, which were for the most part with hematologic malignancy, 70% of the people that were in this group were hematologic malignancies. There were 192 children in this group, and they found that about half lost their antibody titer to Hep B after treatment, and then a smaller percentage for the rest of these, the measles, mumps, and rubella about a quarter, and then tetanus and polio less than that. But then once they got a booster, most of them recovered their immunity. They found that the titer losses were linked to profound lymphopenia, not so much the neutropenia, but the lymphopenia, and also the longer B-cell recovery time. So that the majority of the patients in this population were treated for hematologic malignancies, especially B-cell acute lymphoblastic leukemia. So it may not be something that you can extrapolate to all patients all the time, but it just gives you some idea. So again, they found decreases in intramedullary plasma cell counts, and younger patients had more persistent alterations. But I think that the point of this is that you may or may not consider checking titers on patients, especially if they had hematologic cancer, just to see whether they still have those protective titers. And then if they don't, then giving them a booster should give them that protection that they need. So here is where I wanted to go over some resources for you where you can find a lot of really well organized and good quality information. The American Society of Clinical Oncology has a website with information about some of these late effects, specifically the peripheral neuropathy, fatigue, psychosocial problems, fertility preservation, and they have more in-depth information about colorectal, prostate, and breast cancer. And you can also find those survivorship care plan templates there. And it's www.cancer.net. And by the way, I have no disclosures of any financial connection with any of these things. So just, I didn't say that at the beginning, but these are just really good resources. And then in terms of the NCCN, they have disease-specific guidelines for adult onset cancers, and there's a list along the side there that has all of the cancers that they have specific guidelines for. This is a free site where you just need to register as a healthcare provider. And it has a lot of information, and it's frequently updated. So hopefully what I've given you is just an idea of where to find more in-depth information, and also I would like to encourage you to check back as it does change. And then the last one is for childhood cancer survivors. The Children's Oncology Group has a wonderful website, the www.survivorshipguidelines.org. They have guidelines with literature support. They also have treatment templates, and then they have great patient education materials as well. And so here's just a last quiz because these are fun. A cancer survivor should not be vaccinated, yes, no, or it depends. Aha! Perfect. All right. So, okay, we've got yes, we've got no, and we've got it depends. I am going to open this up for questions. I don't have more to share with you at the moment, but I do want to answer any questions you might have. I think we're going to be doing it by the text box here.
Yeah, and we just have one more question too for the poll, just in relation to just your overall understanding of the fascinating information that was presented today. I have a better idea of what factors impact a decision to vaccinate and where to look for guidance. So if you guys can answer that as well, that would be super helpful to us and to Charmian. Yay, it was a success. Everyone has a better understanding. Perfect. Well, thank you so much, Charmian. Before we say goodbye, we'd like to offer, like we had mentioned, a little more time for last-minute questions. So please type those questions in the chat box now. While we are waiting for those questions to be typed in, just a couple of reminders. If you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended, or in your post-webinar email. The email will be sent out by the end of today, and all CEUs will be mailed out within the next week. And if you'd like to view or share this webinar, the recording will be available on our website along with information for future webinars at immunizenevada.org/webinars. We should have that up within the week. Our wonderful comms team posts that for us. And one question that we had that came to me directly that I posted to all was, if a cancer survivor was to come into, say, a community health clinic or health district office for immunization, would you recommend that clinic staff refer the patient to their primary care physician or specialist who may have a relationship with the oncologist, or a more thorough understanding of their historical health information?
Well, that's a good question. I would say when you're doing your assessment before you give them their vaccination, find out how long it's been since they've had treatment for their cancer. So if they had treatment recently, then you might want to refer them back, like within the last 3 months, because especially if it was cancer chemotherapy or radiation that affects some of their immune system organs, such as their bone marrow, or that would be like total body radiation or radiation to their pelvis or their long bones where they're making the marrow. If it was again, it really depends. If it's a patient who had, for example, a non-complicated cancer treatment which involved localized surgery, maybe some localized radiation, and it's been more than 3 months since their treatment, they can get their vaccine, especially if it's a inactivated vaccine. If it's a live vaccine, it would probably be okay for those patients to get it if they needed it. But if it's somebody who's had that systemic chemotherapy and it's been very recent since they've had that done and you don't have information about their labs and things like that, then I would refer them back to their primary care for sure.
Perfect. And then the next question was, will participants be able to download the charts on vaccines that we used? And I can answer that. We will post the slides in addition to the live webinar recording on immunizednevada.org/webinars. So you guys will be able to take screenshots or whatever you choose with those slides that we include up on the website. No problem. And then another question came in. Do you know the interval between the 3 doses of Hib, TD/Tdap, Hep B, IPV, and HPV for HCT survivors?
Well, that is all in the NCCN guidelines. I didn't put it on there because it would have been a very busy slide that way. But they do have it listed. If you go to the NCCN guidelines, it's under the Immunizations and Infections section. And yep, they do have it. I would look there. And again, I would look back each time you wanted to do it just to make sure there hasn't been updates. And I would definitely just check with the Transplant Center. Sometimes they have their own specific schedule they want their patients to use.
Perfect. Looks like that is all the questions that we're seeing come through right now. If there's anything that we can address post-webinar, please feel free to send us an email at info@immunizednevada.org, and we'll be happy to forward those questions along to Charmian and her expertise. And otherwise, we can try to answer those to the best of our knowledge as well. But other than that, it looks like we will conclude today's webinar. Again, thank you so much, Charmian, and all of those who participated today. I know that I especially love the information about the ideal versus the real-world practical applications of vaccine recommendations and administration. As we all know from being in this field and in public health in general, those two don't always align. So I appreciated you mentioning that as well. So perfect. Thank you again for joining us today. And again, please refer to the follow-up email if you're wishing to redeem those CEU credits. Thanks so much, everyone.
Thank you.